ambalo nilitenda, nataka toka leo nimwonyeshe pendo, niimbe pendo lake sifa kuu, nitatoa akafa niwe hai, niimbe pendo lake.
So we'll take another choice. Okay, song number 74, SDAH.
I call upon choristers, Upapa and Anani. Number 74. Yes, someone. Song number 74, SDH.
Okay, song number 92.
Song 92. This is my Father's world. Sing. This is my Father's world, and to my listening ears all nature sings, and round me rings the music of the spheres. This is my Father's world. I rest in the thought of rocks and trees, of skies and seas. Is on the wonders wrought. This is my Father's world. The birds their carols raise, the morning light, the lily white, declare their Maker's praise. This is my Father's world. He shines in all that's fair. In the rustling grass I hear him pass. He speaks to me everywhere. This is my Father's world. Oh, let me never forget that though the wrong seems so strong, God is the ruler yet. This is my Father's world. Why should my heart be sad? The Lord is King, let the heavens ring. God reigns, let the earth be glad.
We'll have her, then we'll have a suggestion from Gogo after that.
Happy Sabbath. Good afternoon. I am here for a correspondence. The board on the 17th of November voted to have the following transfer in: Victor Mutiga Karithi from Nyambaria High School to JKUSDA. And the board on the 23rd of November voted to have the transfer out: Dorcas Ambaisi Bukachi from JKUSDA to Mwangaza SDA Church. This is the first reading.
Happy Sabbath. Happy Sabbath. Happy day. So before we begin, let's pray. Almighty God, we come unto you this time of the day, thanksgiving in our hearts. As we want to begin the next session of learning, Almighty God, may you open our hearts to understanding, and may you bless us in it. This is my humble prayer of faith, believing and trusting in the name of Jesus Christ, I pray and believe. So I'll allow our speakers to introduce themselves.
Happy Sabbath. Happy day. My name is Davis Onsare. I am a young medical officer, and I'm glad to be with you today for this very important discussion that we're going to have. Thank you.
Okay, God is good all the time. Joshua Amenya, pleasure being with you.
I'm Terry Opiyo. I'll be the moderator. So today we're going to speak about three things. We have cervical cancer, we have breast cancer, and we have prostate cancer. And all these three affect both male and female. And for today, we're going to start in the order of breast, then cervical, then prostate. All right. Listen. So I'll direct these questions to our speakers, and I'll request you to, the way tulifanya Thursday, the simplest explanation you can give, so for them to understand. So what is breast cancer, and who are at a higher risk of getting breast cancer between male and female? Ni kina nani? Kwanza tuanze na hizo mbili, then I continue.
Okay, God is good all the time. Yeah, I think from my experience and training, breast cancer is just a malignant tumor, or it's a cancerous tumor that grows on the breast, usually identified as it can be manifest as a lump, or at some instances the lump may not even be identified, but it's a growth that is cancerous. The word is malignant, that usually is present in the breast. And usually it's common in women. It's men. And breast cancers usually have different varieties. There are breast cancers that are triggered by hormonal implications. Usually, there is a test that is done to assess that it's hormonal. There are some that are triggered by abnormal protein that are identified during testing. But at the end of the day, the borderline is that breast cancer is a growth that takes place in the breast that is usually malignant. That is why it's cancer. And there are some other tumors that can grow in the breast that are non-malignant, but over time they can turn to be malignant. Risk factors, usually from lifestyle medicine perspective, women who have a high risk factor for breast cancer are those ones who, number one, are exposed to severe hormonal imbalances. In fact, in our assessment, hormonal imbalances that are very severe are a foundational cause for both uterine cancers and tumors, and also breast, because they have an attachment to estrogen. The second thing that commonly underlies breast cancer, there's a genetical attachment to breast tumors, just like prostate, that I think we will also look into. Number three, there's a dietary implication. I was sharing during the week how high protein diet contributes to a large degree to early maturity in both sexes. You remember, during the week. Diet has implications to cancer of the breast. In our assessment, high-fat diet, low-fiber diet, diet that is deficient in nutrients, vitamins, and some of those major things could actually lead to the development of breast cancer to a large degree. So I think that's what I can say probably in a nutshell about breast cancer to answer that question.
Okay, thank you so much. Onsare, I'd like you to tell me, how do I know as an individual that I have breast cancer? You know, what are the observable signs in me as a person that will implicate I have breast cancer?
Okay. Maybe before I answer that question, I want to give you a few fun facts about the breast. The breast is a modified sweat gland. If we date back to, if we go back to the development of the breast, usually, breasts start developing from around the 4th week of gestation. And another fun fact, apart from the fact that the breast is a modified sweat gland, during development, you can't differentiate a dog from a girl, because how the breast develops, usually there's a ridge that starts from here, from the axilla, goes all the way down to the groin, and along that ridge, breasts develop. And as the embryo develops, there are other breasts involute, and you remain with these normal breast tissue you're used to.
They disappear. Yeah.
Yes?
Involute.
Involute, maybe I'd say they disappear. Yes. So you wouldn't differentiate a girl from, I don't want to say a dog, but a dog, sinagonga hivyo. Yeah, those are the very fun facts about the breast as a tissue. So the breast is composed of a fibrous tissue, it's composed of fat, it's composed of glandular tissue that produces the normal lactational milk that we are used to. So, just as Tumisha said, a cancer is unregulated growth of cells. Usually, cells grow and they reach a point, they die, a process we call apoptosis. But in cancer, that process is in some way due to mutations, what Mtumishi has been saying, due to mutations and other risk factors that he has talked about. That process of the normal cycle of the cell is, yes, we don't have the normal development of the cell. You know, the cell that is cancerous does not die, does not undergo the normal apoptosis. So how will you know that, how will you suspect that this thing that I'm feeling is suggesting breast cancer? One, breast cancer can manifest as a lump, just as Mtumishi has said. And if, I don't know if you have time, we can talk about lumps. Because the lumps that most of us are used to are physiological, things we call physiological. They're normal lumps. Throughout your menstrual cycle, the breast undergoes changes. And those changes are, just as Tubishi said, as a result of the hormonal changes in the normal menstrual cycle. So at some point of your menstrual cycle, especially when your estrogen and progesterone are high, usually mid-cycle when you're ovulating, you might actually feel some lumps that are most of the time painful. But breast cancer, rather cancerous lesions, I hope I'm not taking too much time, usually, in most cases, they are painless. And if you try to palpate, if you try to feel them, they have irregular margins. The surfaces usually are very irregular also. And they can be associated with other features like features of this, surrounding the skin of the breast can have dimpling. There's a feature we call pudendrange, whereby your breast looks similar to what do you call it? An orange. You see how oranges have those small.
Like the skin of an orange.
The skin of an orange. The other way breast cancers can manifest will be, we also have nipple retraction, thank you, Terry. And another way they manifest include discharges. And we can also talk about discharges because there are discharges that are physiological. For instance, breast milk, that's a discharge that is normal. There are discharges that sometimes you can have yellow discharges, sometimes even green discharges. So different types of discharges suggest different etiologies. Yes, those are ways that we can suspect that a breast lesion is malignant. And if we are talking about advanced malignancy, especially if we have something we call metastasis, whereby the cancer now spreads to other areas of the body, you can manifest differently. I hope we will discuss that. Thank you.
Okay. So basically, for you to just know you have breast cancer, when you look at your breast, either it has dimplings, kamba it is an orange skin, venye an orange looks like, ama your nipple imeingia ndani. Ni kama kuna kitu inaivuta ndani. You see? And then there's a change, you can have a change in color with regard to the skin of your breast. And also, in addition, you can have different kind of discharges coming from your breast, apart from the normal ones. Okay. Now, Daktari, could you describe a self-examination? Because I'm certain this is very important for anyone to know how, as an individual, can I examinate myself to know that I have breast cancer? Could you demonstrate it for them to know? Are you in a position to?
Okay, I think that's very important. One of the key things that I believe my brother has already shared is that early diagnosis or early assessment of cancers usually plays a key role in therapy. Most of the time, people tend to find out they are sick from cancer when any intervention, even if it's from alternative medicine approach or conventional, is almost incapable of yielding much because it has gone so far. I have met people who have had lumps from high school, and they've gone all the way with it, all the way past through campus to discover it's stage 3 breast cancer when they are getting married. Simply because a small examination or a sign that they would have seen earlier, detected, taken measures, would have saved them a lot. So like she's saying, actually, there are methods, there are ways by which an individual can perform an examination to be able to just determine if what you are dealing with is a tumor or a growth that could be cancerous, and signs that could indicate that you need to visit a medical doctor or to do further assessment. So there's something Doc has said about breast cancers, is that generally they tend to be irregular. When you are touching the breast or when you are doing an examination on the breast, you will realize that if something relates to cancer, cancer cells, like he said, are growths that are not regulated. They don't follow any pattern. It is just increasing mass of cells, proliferation of cells that simply multiply. They don't die, they get bigger. So generally, women can have some time to examine their breasts. And one of the key things is looking at the tip of the nipple. Like she said, the direction it's facing, is it folded inwards? The kind of, if the woman is breastfeeding, the kind of discharge that is being produced aside from the milk can also be able to determine if there is a problem you are having. Some tumors can be painful, but like Doc has said, some are very painless. So you may not even identify that through the aspect of pain, whether it's a tumor. But at the end of the day, it's an irregular mass or a lump that you can feel on your breast. Number 2, it may alter the shape or the appearance of your nipple, meaning it may look protracted, it may look like it's bending inwards or it's folded sideways. There's a discharge that could be produced. But I think sitting at a mirror and assessing, looking at the area, trying to touch the place where you're feeling the mass with your hands and feeling through. How does it feel? What is the texture? Those are things that a woman can do generally. But from my standpoint, I think generally the appearance of an unknown mass on your breast should warrant you not just to do an observation of your own, which you can do daily after taking a bath, or regularly once you are from taking a bath and you are probably putting on your bra, or you are preparing to leave the house. Any presence of an unknown lump or mass should warrant you to visit a medical facility, just so that it can be assessed much further. But those characteristics are very key and common. One, I've said it may be painful or painless. There may be a discharge. You may not even be breastfeeding. That is coming out through your breast. That is unnatural. The other thing I've talked about is the color and texture of the breast may even be different. It may be scaly. It may look puffy, something that when you press into, it's not like the normal texture of the skin. Those things should warrant you to want to go for an extra checkup so that you may verify if it's normal or there's something growing. And something Doc has said, not all growths on the breast are cancer. Sometimes you may be having a cyst. Sometimes you may be having a normal lump, just a tumor that is not malignant. But at the end of the day, from a layman's perspective, any presence of something odd should warrant you to see a doctor just so that it can be verified that it is normal. Then you can move forward. Like I said, early assessment will determine early treatment, which to a large degree is success for breast cases.
Okay, thank you so much. And sometimes you can find a lump is also under your armpit. You see, it's because like most of the waste products in the body zinaenda through. Na nakumbuka lymph nodes mahali. When you're in high school, someone talked about lymph nodes. They manifest with a swelling under there. So basically, what I really needed ni to unionyeshe. Unajua? Okay. Am I just to do it in a very fast way? Sindio? Listen. When you're doing your own self-examination, apart from the normal things you'll see, you will, now it's palpating, okay? Utaanza from huku, katikati, kienda huku, towards your lymph nodes, towards your armpit. So it is just a basic palpation to feel if you have a lump on your breast. You see? Now I have a question. For men, is it too evident? Because, you know, they don't have the fatty tissue. So yao ni too flat. Is it, when they have the lump, poleni, when they have the lump, ni nini mnacheka si ni ukweli? It is too evident, like, mtu akona lump, sa aende angaliwe.
Okay, thank you for that question. I have to point that I've not seen a male patient with breast cancer.
Okay.
But when Terry was telling me about, you know, I had requested that we discuss these two topics. And she was like, what about the men? I told her, but see, we are discussing breast. And men have breasts. Like, okay. The fact is, men have breasts, and we all know that. And the thing about male breasts is, as opposed to female breasts, the breast tissue is little. Just like I said, the female breast has a lot of fatty tissue, has a lot of fibrous tissue, has glandular tissue. But for males, it's very limited in terms of tissue. It's just a small nipple and some tissue. Beneath it, you have muscle. So, in my own understanding, if a man develops breast cancer, it will be more evident that they have cancer as opposed to female. One, because it's not normal for a man to have swellings in the breast, one, the first thing. And two, it's, they are quicker to seek medication, especially considering the mental implications of breast cancers. So they are more evident.
Okay. Thank you so much. Could you speak about the stages of breast cancer in a nutshell? They're just, I think there are 4.
So, I don't know why Terry wants us to talk about the stages of breast cancer. But in a nutshell, there are 4 stages of breast cancer. 1, we have stage 1 to 4, we all know it. Stage 1 being the, you know, the asymptomatic, the very, very asymptomatic, all the way to stage 4, where we have metastases and spread to, we have local spread 1 and distant spread. When breast cancer metastasizes, it can, metastasis, just as I said, is distant spread. Can have spread to the brain, can have spread to the bones, can have spread to the liver, and those metastases, they have different ways of presentation. For instance, if we have spread to the bones, a person can present with bone pain. If you have spread to the liver, people can present with jaundice, yellowness of the eye. So apart from really these things that we have talked about, the breast, when we are examining a patient, we suspect could be having breast cancer, we screen them as a whole. We screen through all the other systems because of the propensity of the breast cancers to metastasize. Yes.
Okay, thank you. So ziko nne, stage 1 to 4, stage 4 being the worst, penye sasa it spreads to the rest of, to other organs in the body and other things, and it presents itself in different ways. Now, I would give you 2 minutes on this one. Tumeongelelea risk factors, sindio? Risk factors we have obesity. Okay, lifestyle can include obesity, alcohol consumption, smoking, etc. And sedentary lifestyle. And then for other factors, we have genetic mutations, family history, prolonged estrogen exposure. For this prolonged estrogen exposure, just to make it clear, sana, estrogen promotes the growth of these cells. So its exposure is what brings you to, have the high risk of getting breast cancer. So on prolonged estrogen exposure, explain, there's na age, hizo tu sasa. So nitakupatia age, estrogen na family history, nitakupatia genetic mutations na obesity, alcohol na sedentary, hiyo ni lifestyle. Hizo, yes.
3, estrogen?
Prolonged estrogen exposure, family history, and age.
And age.
Yes.
Okay, one point maybe I can say about the part that Doc has spoken about the stages that breast cancer goes through. I think in my experience, once the breast cancer has taken a turn to metastasize, usually it larves the lungs. Majority of patients who come to us for breast cancer therapy, alternative medicine, usually come when they're already coughing or they have a lung condition, or they are manifesting severe inflammation of the lymph nodes. Either they can't move their hands well because close to the breast are some attached lymph nodes. So generally, if the breast is limited, the cancer is limited to the area where the breast is, then it's in the earlier stages. Once it begins spreading to the lymph nodes and begins going to the other organs around the breast, then usually it's around stage 4. And most often, the liver and the lungs are culprits. And usually when the liver and the lungs are already affected, even using natural medicine, the chances of survival are usually very minimal because the liver is a master organ, the lungs is also a master organ. They are doing very important functions. So with progression of the disease, you find it is easy to reach a critical condition. When it comes to breast cancer with age, one thing I can say is breast cancer is more prevalent among people who are more fertile, of a younger age before people get into menopause. And this is because of the hormonal effect that she's talking about. Estrogen is ideally in women is a growth hormone. And estrogen is responsible for the development of the breasts themselves. Estrogen is responsible for the development of the womb, the development of the endometrium. They are likely much more to get breast cancer, and there's a high incidence among them, merely because of the implications of the hormones. Now, one thing I have come to learn, that's why I was talking about the risk factors. Any woman who already has challenges with fibroids, they have challenges with severe hormonal imbalance, they have challenges with non-malignant tumors in the breast. I'm talking about cysts and such like kind of things. They always have a higher risk of having breast cancer. In fact, after a couple of years of having those challenges, they should always be monitoring if they would be having a risk of breast cancer because of the estrogen factor. Estrogen, because it enables growth, we said cancer cells operate in what way? It is rapid and regulated proliferation of cells, or division of what? cells. So whatever in the body can be able to trigger that will actually accommodate that. And there's something we discovered about animal protein that I shared earlier. Milk and eggs, even though they are ordinary food, they contain a bit of hormones from these animals. There are hormones in milk that come from the chicken. And there are hormones in, not chicken, from the calf, from the cow. And then there are hormones in eggs. A good percentage of that will interfere with the human balance of hormones. Number two, women tend to use lotions. And most of these lotions have synthetic estrogen. They will always come in names of paraben, either 1,3-diol paraben or paraben in many forms, but they're usually found in lotions. And this synthetic estrogen has a way of increasing the amount of estrogen within the body, and that to a large degree can also trigger the amount of estrogen that can consequently lead to the growth of tumors and even cancer itself. That is why we say you need to check the kind of lotion you have and the ingredients that are found within it, because they may make your skin soft, but they may also tamper with your hormones. Number three is estrogen.
Before you continue, paraben.
Paraben.
P-A-R-A.
P-A-R-A-B-E-N.
Please go check your lotions.
Go check paraben. You can read about paraben itself. It's very common in some of the lotions that are actually brought to Kenya to a large degree. Another thing is the use of contraceptives. Contraceptives can, to a large degree, interfere with the balance of progesterone and estrogen. And like I said, estrogen is a major factor when it comes to tumors and growths in women. So, there are contraceptives that are estrogen. Contraceptives, the main factor there is estrogen. So those ones have increased the risk factor when it comes to getting not just breast cancer, but even cysts and growths that are present in the body, and also use of contraception to a large degree. Another common thing that I think relates to the estrogen issue in women is a high-fat diet. There is a correlation between production of estrogen in the body with the amount of fat that is consumed. It's interesting that this is something that is researched. So women who are having high fat, that is why I think he'll be coming in on the issue of obesity, tend to have a higher risk of having breast cancer than women who are slender. I'm not saying that all women need to be slender, but I'm just saying that there is a correlation between that and estrogen. That is why in lifestyle medicine, we recommend that women be taking a lot of soya, because soya has a compound that mimics estrogen. So the body assumes, the body is fooled that it has a lot of estrogen because of the estrogen mimickers that are found in soya. So that plays a role. The third thing you told me to talk about was age, estrogen relevance,
family history.
And?
Family history.
Family history. I don't think there's any cancer that does not have a relation to family history, be it prostate, be it breast. Most of these tumors have a family history because cancer takes place on which level? DNA, isn't it? The mutation takes place in the DNA. So to a large degree, we can inherit already defective or weakened genes from our parents, and the predisposition to have cancer is higher in an individual with a family history of that cancer. That is why when you go to a doctor's office, they want to find out, do you have someone in your family who has prostate cancer, who has breast cancer? Because they want to determine if the risk factor is higher in your own what? In your own life, because there is that possibility. But at the end of the day, we say heredity loads the gun, lifestyle pulls the trigger. Meaning even if the gun is loaded, all your uncles are having prostate cancer, or a good number of your aunties have breast cancer, the possibility of having it will determine on the lifestyle choices that you make that may be similar to the ones that they made that brought the what? Brought the cancer. So heredity will load the gun, meaning you are predisposed. Family history can play a role. But what pulls the trigger? Your own lifestyle choices. It's how you live. It's what you live that will trigger those genes or probably bring into perspective of either initiating and promoting the cancer, and which lifestyle plays a major role.
Thank you so much. Mmejifunza, si ndio? Haya. Now, other risk factors. We have genetic mutations, and then kwa hiyo lifestyle kuna mambo na obesity na alcohol intake. Yes.
Okay, thank you. Thank you for that question. Maybe I want to talk about estrogen first. Just briefly. The thing about estrogen is most breast cancers are hormone responsive. They respond to circulating hormones. And one of the hormones, as he has said, is estrogen. Now, the amount of time a woman is exposed to estrogen will determine the risk to breast cancer. If you have you started getting your menses earlier than normal kids, that is what we call early menarche. If you get your menopause late, that means the time period that you have been exposed to estrogen through the normal menstrual cycles is longer than the rest. You are at high risk. So early menarche, late menopause. Another thing is the time at which women start families. Do not stone me or do not misquote me, but if you start your families late, you're at risk. Usually, I don't want to talk about the age of starting families. You can go and find out. So that tusipangiwe harusi kesho. Whether or not you breastfed your children and how long you breastfed them. That is part of the exposure, estrogen exposure we are talking about. About genetic mutation.
Wait. So let me ask. A woman who hasn't given birth at all has a high chance of getting breast cancer, right?
Yes, yes.
Give birth.
Zah. But Terry, do not start these things tomorrow. I remember I've just told you to go and find out. Have you heard about prophylactic mastectomy? From what to which he said, there are people who are at very high risk of breast cancers. They get their breasts removed before the risks catch up with them. We have we are SDS, but we have a very wanaitwanga hawa tu wanakuwa followed sana. Yeah? There's a lady who did that. He's very famous. She's very famous. I don't know the name. So there's that. So let me talk about genetic mutations.
So, your prophylactic mastectomy ni kutoa tu both breasts surgically. Imagine, that's simple.
You're given prosthetics.
Okay.
Yes, it's not bad.
Talk about the genetics.
Genetics, we have gene mutations. We have there are genes we call BRCA1 and BRCA2. So in case you have those mutations at the gene level, that's BRCA1 and BRCA2, you're at increased risk of breast cancer. Also, there was something I wanted to talk about, gene mutations. Yes, family history. just as Mtumishi said. Usually you are at increased risk if the first degree relatives have breast cancer. And the risk increases further if they got the breast cancer earlier.
Who are first degree relatives?
You can tell us that, Terry. Your sister, your mother, your who?
Brother.
Yes. Yes, those are first degree relatives. And the earlier they got the breast cancer, the higher the risk. Yeah. So you go, if you think you're at increased risk of breast cancer, you're tested for genetic mutations, and from there they decide whether, if you have not gotten the cancer yet, whether you can get your mastectomy done. Thank you.
Okay, so just to finalize on breast cancer, what are the treatment plans for breast cancer? Mtu hufanyiwa nini akishapatikana nayo?
Okay. Maybe you can talk.
Okay. So, you're asking us hard questions. But for breast cancer, it depends. Just like we said, it depends on the staging of the cancer. We have localized disease, disease that has spread locally, and metastatic diseases, metastatic breast cancer.
Said there is radio that could also be done. Usually, most people do it as a follow-up after surgery. Some people do it within the area. Then we have chemotherapy that can also be done at the same time but most people, for breast cancers, usually most oncologists prefer that the patients are introduced to a chemo, then a surgery, then a radio. So you can have them all done at the same time, especially depending on the staging of the cancer. And the age of the patient plays also a factor. The status, the health of the patient at the time of diagnosis also plays a factor. But those three are the major ones. They can be done either in reversed order, one beginning before the other. There are some people who do surgery, then they do chemo immediately after, because surgery can sometimes trigger the spread of the cancer itself. Now, on lifestyle medicine, because I have to also talk about that, we have packages that patients are given if they have breast cancer. One package is for patients who are adamant that they would want to do a chemo, a radio, or a surgery because the tumor is aggressive and they want something very strong to help them remove the tumor. So we offer a package where lifestyle medicine is used to cushion the effects of chemo and radio. Chemo and radio generally are very explosive in nature, and they weaken patients because they are chemicals that, though they are fighting cancer cells, they also fight the body. Any cells in the body that are quickly multiplying. Example is blood, hair, other parts of the body, mammogram test to assess if their blood levels are normal. So lifestyle medicine can help a patient when you incorporate juicing, diet, and some other things to a certain degree. You must do it with wisdom. A patient can endure chemo without suffering severe complexities that come with the adverse reactions that come along with it. The second thing that you can find in lifestyle medicine is post-surgery therapy. Most people don't want to go for surgery because it is a fact. It is believed, but it's a fact, that surgery can propagate the spread of cancer. I have seen people who have a breast cancer, they've gone for surgery, and then in 2 weeks, they did an MRI or a scan, and it showed the cancer was just located within the breast. After the surgery, there was no cancer. Then 2 weeks, they are coughing. Why are they coughing? There was a very quick metastasis, what he was talking about, that has gone probably into the lungs. So by the time they're doing a test to assess that, it's already spread. So we do a follow-up for surgery. There are certain herbs that have properties that can actually keep the body in a state where cancer cannot grow or spread. The third one is we have lifestyle medicine offers therapies for cancer patients. The good thing about lifestyle medicine is there are herbs and certain foods that can block estrogen production and even stay your periods so that your body does not have estrogen production high. That means that what he was talking about, cancer that are responsive to estrogen may not find food or fuel to keep them going. Then there are herbs that operate like chemo. They are able to disintegrate tumors, but they have to be given with wisdom and skill. The interesting thing about breast cancer management in natural medicine, if you ever hear someone say that wanatumia remedies kutibu breast cancer is one of the most stubborn to treat naturally. Of all the people I've ever seen, breast cancer naturally can take 2 years or 3 years of treatment. Kabla ipote. So if you hear someone saying, oh, 1 month breast cancer, oh, walipelekwa wapi akapona, uongo. Breast cancer is very stubborn, and if you're using lifestyle as an approach to help, even after surgery and after some of those things, the patient has to be on a long-term therapy immune system. So I think that's what I can say about the immune system. So I think that's what I can say about the options of treatments. But at the end of the day, I would advise the options of treatments. But at the end of the day, I would advise people who are diagnosed of cancer to seek counsel from both parties. Visit your oncologist, have assessment of the treatments, logically assess those treatments, then visit nutritionists and lifestyle medicine practitioners also and find out, is it possible you find a way of putting a balance? Can you caution the effects? Do you really have to go for the chemo and surgery at the same time? Weigh those factors very well. But at the end of the day, nature is the best restorer. Thank you.
Okay, thank you so much. I think we've learned a lot about breast cancer, and you're aware, right? Are we aware? So I'll close on breast cancer. I'll go straight. So I'll close on breast cancer. I'll go straight to cervical cancer. So Sapa, you know, men are also the mosquitoes. You'll understand. So we'll go to breast cancer. When I say mosquitoes, I'll say that they're the carriers. I mean cervical cancer. So what is cervical cancer? What are the causes, or rather the risk factors for cervical cancer? Are men the carriers for cervical cancer? And if they are the carriers, what is the effect in their lives? And then after that, I'll go to the next question. So what is cervical cancer? What causes cervical cancer? Are men the carriers of cervical cancer? And if they are, what is the effect in their lives?
Okay. Now that we have defined what cancer is, cervical cancer is cancer of the cervix. Yes. Okay. Let me talk about the anatomy of the cervix for the men. I know most of them know, but let me just talk about it. The cervix is part of the uterus, and it is inpoaching of the uterus into the vagina. If this is the vagina, all this is the vagina, and this is the uterus. This is the uterus. What you are seeing from there should be the cervix. That is where the cervix is located. When we are doing screening and we want to look at the cervix, we open up the vagina and we're able to visualize the cervix. So that is the anatomy in a nutshell. Fun facts. I want to talk about HPV, human papillomavirus. 80% of women are infected by human papillomavirus by the second year of the first time they had sexual contact. 80%. The first time we have sexual contact is called koitaki. The good thing is, most of these women with the HPV infection, another 80% of those women recover from the infection naturally within, I think it should be another 2 years. But the remaining 20% have a progression of the infection, which is the major risk factor for cervical cancer.
Okay, before you continue, what is HPV?
Human papillomavirus.
Yes, what is human papillomavirus?
Okay, so you want me to talk about how it infects
No,
the pathophysiology?
just what is it?
It's a virus, it's a viral infection. I really don't know what Terry wants me to talk about. Okay, let me talk about transmission.
I want you to say it's a sexually transmitted infection.
Okay, let me talk about the transmission then. So it's sexually transmitted, as she said.
It's an STI.
Yes. And so, the risk factors. Now that HPV is sexually transmitted, so sex has to be in the picture. So, we have talked about koitaki. If your koitaki was early, you're at risk. If you have many sexual partners, you are at risk. If you have high-risk sexual partners, high-risk women, if you sleep with, they're called sex workers. Yes, if you have a partner with many other sexual partners, you're at risk. And these risks are increased by issues like ulcers within the cervix. We have HIV infection, use of combined oral contraception, which is very commonly used even among us university students. If you have an active STI that ulcerates, the probability of HPV infection triggering or you going through the whole process of, there's something we call a cervical intraepithelial neoplasm. So we have, it's CIN 1, 2, 3, 4. So as you progress, you move towards, from CIN 1 to 4, you move towards cervical cancer. So if you have those risk factors and the additional risk factors that trigger progression of the infection towards cervical cancer, you're at very increased risk. Okay, a minute please. Let me talk about smoking. Just a minute. Cigarette smoking. There are conventional ways by which cigarette smoking causes cervical cancer. No, you know the conventional ways. There are the unconventional ways by which cigarette smoking or tobacco causes cervical cancer. Studies have shown that men who smoke have carcinogens in their sperms.
What are carcinogens?
Carcinogens are cancer-causing substances in their sperms. So those are new studies that actually show that you could not be using tobacco, but if your spouse is, and they have those carcinogens in their sperms, then you are at risk because the sperms come into direct contact with the cervix during intercourse. Another unconventional way is nicotine staining. When you take your cigarette, your fingers are nicotine stained. And the unconventional sexual behaviors among men, there are people who use fingers, even in marriage, that is. So if a man has nicotine staining in their fingers and you do those unconventional ways of having sex, I don't know whether I could call them unconventional, you are at risk because of that direct contact, not direct from the cigarette smoking itself, but from another person. Thank you.
Okay. Could you state to me how HPV presents itself? If it's the major cause of cervical cancer, how does it present itself in an individual?
Okay, HPV presents itself just like it's an infection. And generally, the presentation of HPV will come as a form of a discharge. Most people who have infections of that nature will have a form of a discharge. The interesting thing is because it's viral, the discharge may not be like having pus, and it appears the normal discharge that comes with bacterial infections. It's normally watery, but there are other signs that would give a lead of exactly how somebody would know that you have cervical cancer. Generally, one major incidence is pain during intercourse that is unusual. Not talking about ordinary pain that women may have during intercourse, but constantly you're having pain during intercourse. Of course, I'm talking to married people. The second thing, being that there is a church setup, the second thing that could be is blood after intercourse. That also could be a sign that somebody could use. Another thing is very heavy menstrual cycles, very heavy flow that is unnatural or odd, and severe pain within the abdominal area can also be another sign that somebody is developing cervical cancer. And another thing is a foul smell. That could also be for the HPV or for the cancer itself. There's just a foul smell, either in the discharge or in the female genitalia. So if you interact with anyone, they can tell that there's a foul smell that is emanating from that individual. So those can be some signs that somebody can look up to when they either have the cancer or... but most of the time, people discover they have HPV when they already have the cancer, because they assume it's a UTI, or they assume it's a minor infection that will go away. That's why you find the ratings for this, finding out that someone has cervical cancer is very rare. Early staging is very rare, because people begin to figure they have the disease once it's already taking a big toll of the body.
What about warts?
What about?
Warts.
What about what?
Yes.
The symptoms?
Yes.
That could be manifesting for what?
No, like does HPV also present as warts?
Maybe you can come in.
Yes. For HPV, we have high-risk HPV strains and low-risk strains. So what he talked about is high-risk strains. Have HPV 16, 18. We have other HPV strains. So those low-risk strains can manifest as genital warts. And warts, by definition, are tiny growths in the genital areas. How can I describe them? Yes, there are growths in the genital areas. So when you find yourself with those kinds of warts, then that could be an indication of HPV infection. So therefore, it calls for screening.
Okay. So for females, HPV leads to cervical cancer, right? What about males? What does HPV do to males? Because it's an STI.
I think what I can say about that, generally, we've said HPV is an STI, and to a large degree, if women can be infected, then men can also be what? Men can also be infected. The only difference that I know with HPV when it comes to men, due to the nature of men's reproductive system, most of the time symptoms, even for some STIs and even UTIs, are usually very difficult to even trace. There may be a penile discharge that is dropping once in a while here and there, but it's not as severe as it may manifest when it comes to women. So generally, most men who have HPV don't even know that they have the disease, generally. And the implications may not be very severe as when it comes to women. So according to actually most research, most men who have HPV don't even know that they have it. Women are the ones that the symptoms begin manifesting. And remember, the female genitalia is generally a carrier. That is why it's easy to get, it's like a receiving end. It's easy to get infections. It's easy for them to carry the infection. It's easy to contain the infection. And normally, if left untreated, can go up all the way to other parts of the reproductive system.
Okay. We have two tests for HPV and for cervical cancer. Okay, so we have two tests to determine both. Kuna pap test na HPV test. So the low one, mwagri nane nangelelea HPV na pap smear test and the importance.
Okay. HPV in men, maybe if I can add, it's asymptomatic in most cases, like he has said. So many times we have it, but we can only transmit, and it's the women at the receiving end. But HPV can also manifest as genital warts in men, and it's a known risk factor for penile cancer in men. You asked about screening.
Yeah.
So screening, we have many ways of screening, by the way. The most common are cytological. By cytological, we mean we take cells and we look at the cells under the microscope for atypical features that could suggest malignant transformation. So, in cytology, we have pap smear, the most common, which you know. And we also have another one called liquid-based cytology, LBC, if I'm not wrong. So, for pap smear, first thing we have to see the cervix. So we open up the vaginal orifice, we see it, then we take samples, cellular samples from the cervix, outside the cervix, and within the cervix for screening. So that's pap smear. Another way we can do is DNA PCR for HPV. Another way we can screen for CS cervix is by inspection. By inspection, I mean we look at the cervix, we stain the cervix with some chemicals, and we observe for changes that suggest malignancies. So in most cases, this is what we are going to do tomorrow. For the people who will be coming for the expo, we will be screening for CS cervix. So we have a way we open up the vaginal orifice. We visualize the cervix just as I showed you. Then we stain the cervix with either Lugol's iodine or vinegar. Then a cervix with cancerous lesions can be identified because of how it takes up the dye, and pathological areas change color. So, when we have a positive screen, for instance, we have visualized and we have seen that some areas of the cervix seemingly have pathological lesions, then we take a sample, what we call biopsy. Then from that biopsy, we can make a definitive diagnosis of CA cervix. Yes, thank you.
It's captured very well the aspect of the recommended tests for screening. And maybe the point I can just add in there is that cervical cancer has a very good chance of being totally eliminated using treatment. The challenge is usually early diagnosis. So for ladies who have manifestations of symptoms that could indicate HPV or earlier onset of those symptoms that we are talking about, I think the expo that is tomorrow or any kind of doctor's visits are highly recommended. The challenge, like I said, majority of people get to see a doctor or an oncologist office when the cervical cancer has moved to the kidneys and they're having a kidney issue. So it's the kidney issue that becomes a red flag. So by the time they're seeing the doctor, they have a kidney issue, or they already have severe abdominal pains, and maybe the cancer has gone all the way up to the uterus. And it's moving upwards to the organs, like the spleen and the others that are up there. So generally, I think regular screening is important. And sometimes the pap smear can be done more than once. Yeah, one test may not show. So if the condition persists, you may have it being done maybe after every 21 days. But generally for a duration, just to verify that someone is not having that condition. But I would recommend that primarily under screening, subject yourself to screening as a woman, both for the breast and any that will deal with the cervix. If you're having any symptoms or signs that show that there could be a problem, then wait until an area of your body is damaged, then you come in. Because at those levels, it's hard to do anything on either sides.
Okay, on the same, a vaccine is important, the HPV vaccine. How often should it be taken? Like, nimechukua tuseme leo, and then after how long, again, should I take? And maybe for future use, for those who will have children, at what age would it be advisable for them to have their kids have the HPV vaccine? Na tuseme mtu ako hapa ako 20 something. Is it still advisable for them to take the HPV vaccine at this point?
You want to say something?
Yes. Okay. Before we go to the vaccine, my brother said very important things about this topic, and I'd like to add something. One, the age of screening. We have age of screening and age of vaccination. So for screening, they recommended, the current guideline recommend that screening for CA cervix starts at 21 years or 3 years post-coitus. We said coitus is the first time you had your first sexual encounter. So 21 years or 3 years post-coitus. How often do we screen? If you screen today and it's negative, then you will screen again 3 years afterwards, if we are talking about pap smear. It's different for other modalities of screening, of course. Maybe if I can talk about the... Okay. Maybe if I can talk about the vaccines, we have two types of vaccines, and both of which are administered over a period of 6 months. And the age of vaccination in the current guidelines is span between 9 years and 26 years. 9 and 26 years. So, you get your first vaccine today. Depending on the type of vaccine you're using, we have two. We have Cervical and Gardasil. Yes. So for Cervical is usually 0 at the time of vaccination, then 2 months, then at 6 months. The other one is 0, then if I remember well, it should be 1 month, then 6 months. So over a period of 6 months. Yes, so if you're here between the age of 9 years and 26 years, regardless of what we are hearing out there about vaccination, maybe it's time to be vaccinated against HPV. Thank you.
Maybe a point I can add there. They're ongoing, of course, based on the line, lifestyle medicine. There are ongoing controversies a lot about continuous vaccination. Generally, viruses thrive in an environment that has a weakened immunity. And that is why a weakened immunity is a higher risk for HPV, just like any other virus. So I think as you contemplate also on the aspect of having vaccines done regularly, I think as a people we can also consider the option of adopting a dietary lifestyle and other parameters within the confines of supplements, diet, that can boost the immune system generally, because it won't just protect you against the severity of HPV, but also against UTIs, against infections that are prone to cause other more challenges. So I'm thinking on a larger scale, you'll win big if the immune system is strengthened. And the immune system can be strengthened because a weak immune system is an opportunistic venture for viruses and bacteria.
Okay, just tell them the meaning of UTI.
Yeah?
Yes.
UTI is uterine tract infections. I think generally most ladies know UTIs. Yeah.
Thank you. So that is much I would like us to present on cervical cancer. And now that you're aware, if you can, please take an early HPV vaccine for your own good. Amen? Amen. Now we're going to go straight to our last one, which is prostate cancer. And then after prostate cancer, I'll give room for questions. And then we call it a day. So prostate cancer. We already know it's the cancer of the prostate. Now I will not ask what it is. How does it come about? What are the signs that a person presents with prostate cancer? And yes, how achana hiyo. Okay, what are the treatment options? So how do they come about? How does prostate cancer come about? What are the signs and the symptoms?
Maybe I'll begin, then Doc can come in. Prostate cancer generally is, there's a part of the body called a prostate. It's a walnut-shaped part of your body. It's geared towards the area where the penis is, but it's also anchored towards the anus. It's somewhere there in between, but it produces fluid that assists in transportation of the sperm and also nourishment. So it is something that is very important for an active reproductive health in men. Ideally, according to research, the prostate gland thrives largely on certain nutrients that need to be obtained through diet. And it is also regulated well using the production or regulation circumstance using testosterone. So prostate cancer is when that walnut-shaped part of the body has a malignant tumor, meaning it has cells that are dividing rapidly, that are unregulated. That is what prostate cancer is about. And most of the time, prostate cancer can be seen. It manifests as difficulty passing urine. It's common in men who are 50 or 60 years and above. It's rarely seen among those ones who are younger than that age. But generally, it's manifest in difficulty passing urine or reduced force of urine. You know, when men go for a short call, it projects. If the force of the urine is weak, sorry, that can be an indication that there could be prostate cancer, maybe blood in the urine. Blood in the urine can be a sign of prostate cancer. Sometimes it can manifest as total obstruction, meaning you can't pass urine completely, and you may need a catheter to help you be able to pass urine. But generally, it manifests as symptoms with passage of urine, or blood in the urine, or retention of urine, or even holding urine. Some people, it manifests as inability to hold urine. So they pass urine onto their clothes without expecting. So the signs have to do with passage of urine majorly at the end of the day.
Okay. Okay. Let me talk about the anatomy of the prostate, just briefly. The prostate, just as he said, we call it walnut. Yes. Shaped and sized. It's a small organ that abuts the bladder. So, if this is the bladder, my fist, this is the bladder, and then this is the prostate. And within the prostate is, I'm trying to deduce the symptoms he's talking about so that we understand how they come about. This is the bladder, the prostate, and within the prostate is what we call the prostatic urethra. That is part of the urethra that comes out externally through the external urethra opening at the penis. And the relations of the prostate, posterior to the prostate, pneumonia prostate, we have the rectum. You want to add? No. Yes, we have the rectum. So, how do these manifestations or presentations come about? If your prostate is big and if the cells of the prostate are proliferating too fast, you can block your urethra. So by blocking the urethra, you will have a hard time urinating, just as he said. Weak stream, straining. Wale wanaingia kwa choo nasikia you're straining before you actually achieve a stream of urine. Another thing is hesitancy. Jamaa anaenda kwa choo, anasimama dakika 5. Watu 5 wanakuja, wanamaliza shughuli, wanatoka wanamwacha hapo. So you hesitate, it's hesitancy. Another thing is you find yourself that you are urinating on yourself, especially in your sleep. Another thing, because the prostate is close to the bladder, if you have the cancer of the prostate, it can spread locally to the bladder. And therefore, if it spreads to the bladder, it can present as blood in urine, what you said about. It can also spread locally to the rectum. If it goes to the rectum, what you'll have is something we call hematochezia. That's blood in stool, hematochezia. So that is generally the basis of the presentation of prostate cancer, if you look at it that way. If I talk about the risk kidogo niongeze kwa chenye alisema, like he said initially, familial history. If a member of your family had prostate cancer, especially early in their, like he said, prostate cancer starts from around 50 going upwards. More common in us Africans, more common and worse in us Africans compared to other ethnic groups. It's responsive to hormone, that's testosterone. There's genetic mutations. We also talk about BRCA1 and BRCA2 in prostate cancer, just like we talked about in breast cancer. What else did you ask?
Now, we're still on risk factors. So, someone who has breast cancer, someone who has prostate cancer can be confused. Okay, mtu anaweza confuse ati mtu ako na arthritis. Unaona, like someone has, we know when someone has prostate cancer, anaweza present na signs za arthritis. So what would be your advice on anyone who has, say, a relative, ama is experiencing muscle pains, and where exactly do such muscle pains mostly present, na how can they know the appropriate step to take? Yes.
Okay, those are not muscle pains, Terry. Those are bone pains.
Ni bone.
Yes. So, in advanced prostate cancer, the cancer can metastasize, just as we said in CA of the breast. And the prostate has a very high propensity to bone. So, a patient comes to you, they are having those urinary symptoms and bone pain. That could be one indicator that they could be having prostate CA. Also, when patients like that present to us, there is a basic test that we do. It is called DRE, the digital rectal examination. I talked about the anatomy of the prostate and its relations. So, the prostate abuts the rectum posteriorly, pneuma prostate. So what we do? Terry, you want to explain the DRE?
Just explain
so,
it.
We introduce a finger through the anus and try to feel the prostate at the rectum for signs of malignancy. Just as you said, for malignant lesions, their defining characteristics, including you will feel a mass, of course, you will feel the prostate at the rectum. Then you will define the prostate. Is it regular? Is it smooth? Is the surface lobulated? And those are indicators of prostate CA. So if you do the DRE, which is the first test, we usually say the only time you do not do a DRE in a patient is only when the doctor does not have a finger, or the patient lacks an anus. So it's a very quick test just to try to define the prostate a bit and just uncomfortable a bit, but very important. There's another test we do called the PSA. R3. PSA is an enzyme that is secreted by the prostate. So, in prostate cancers, the enzyme PSA is usually elevated in blood. So, we have confirmed that there is a lesion in the prostate that is likely cancerous. We do our PSA levels. Then from there, we do other tests just to try and stage the cancer to see whether it has metastasized. Is the patient presenting with metastasis to the brain, metastasis to the bones, or any other parts of the body? Yeah, thank you.
Okay. Sorry, I'm being warned. Hey, with the time. A question. Why would you advise someone who's experiencing back pain, lower back pain, for a man to go and check if they have prostate cancer?
I think what I can say, I think that's the question you also asked earlier about bone problems. I don't think a patient can manifest stage 4 symptoms when it's in the bones. Generally, it's usually stage 4 or 3 something. It's usually has spread to a large degree. They can't show symptoms of bone problems without already showing symptoms that indicate they already have a prostate issue, like urination, the stream of urine, blood. So by the time they're having issues with their bones, to a large degree, unless in very rare cases, they already had indicated symptoms that would help a physician to narrow down that this is a prostate problem. And most often, I think, before prostate cancers even begin, a lot of patients usually have prostate enlargement, just an enlargement of the prostate. And according to some recent studies, there is an indication that apart from deficiency in nutrients, which I talked about, primarily zinc, some trace elements and other nutrients, overstimulation can also contribute to prostate cancer and even enlargement. What I mean by overstimulation, prostate cancer tends to be higher in men with many children. That's research. And also with a very highly active sex life, meaning very, very active sex drive. So it relates to the prostate to a large degree. So I'm thinking by the time we narrow down to a backbone problem, the patient must have already indicated symptoms that would help the physician clear out the first issues. So if those issues are not present, the ones that point to the prostate and probably a metastasis to the bone, then maybe you can now look at the nature of the back problem. Maybe an X-ray would be done, other assessments to verify if it's just a back issue related with straining, or it could be structural. It could be an issue with the alignment of the backbone that may need you to interpret through a result. But I think If it's prostate related, already you will have some things to query from the patient's symptoms in the other lines that we've talked about.
All right, thank you. I can ask questions.
Maybe I can add one thing. You know, if we just talk about the prostate and we don't talk about what you can do to avoid it and what you can do when you have it, then they will feel like we've been giving a class on anatomy. I think what I can say about the prostate, I want to just do a combination of prostate issues, erectile dysfunction issues, prostate enlargement issues, generally all those things relating to men. What I can say is that prostate issues have a very sensitive significance to diet. And many times when we are conducting health expos, I know you are going to have an health expo tomorrow, we tell women that keeping your men from whole grains. What do I mean by whole grains? Your brown rice, that ugali that is unrefined, those pumpkin seeds, that uji, sorghum, millet, and the others that is from the shamba and well cooked, you are preparing them for a later complication of the prostate. Because the prostate is sensitive, especially to trace elements, those nutrients that are rarely gotten in impoverished diet. That is why you'll find generally men who are eating real ugali, men who are eating unrefined foods, do not have ED problems. Oh, ED is erectile dysfunction. They don't have erectile dysfunction problems. They don't have complications with prostate issues as they grow older. But if you're a man and you're eating sifted maize meal, you're a man and you're eating white rice in your house, you're a man and you're eating these things on a regular basis, I can guarantee you, you will have problems with sexual performance, and you're going to have problems with your prostate as you approach 60. You may not have them now, but you will have them as you approach 60, because that nutrient deficiency will count when you need it most. And remember, prostate problems means almost reduced or no sex life. You know that? To a large degree. So this is an area that I think we need to contemplate on. Number two that I want to just comment on is overstimulation. I think the same thing also applies to cervical cancer. We talked about how many sex partners? More than one. I think the society has made us to see sex as, I don't know how I can call it, ni kama mchezo. Do you know sex is supposed to be within a committed relationship and should be practiced within the confines of intimacy between a man and a woman? Hii mambo ingine ya objects, masturbation, premarital sex, extramarital sex, and all these things are too strong for the body's resource production and management. Nimewapita hapo. Meelewa? Constant stimulation means you're losing a lot of zinc in the semen. You're losing a lot of nutrients that the body can be able to repair and rebuild. So because of that, the deficiency will eventually affect your organs, and the prostate is very sensitive to nutrient deficiency. So I can just recommend, abide by the health principles, and you will, to a large degree, avoid prostate issues. Now, prostate cancer, like cervical cancer, detected early can be treated. So again, subject yourself to tests and screening whenever you have the opportunity. Tomorrow you'll be doing prostate. These people are young also, so I don't think those challenges may be here yet. But generally, I would suggest that a healthy lifestyle will remove a lot of doctors' visits on some of these things that we are now here doing what? Talking about. Now, vile umesema Terry, usually there are people who discover they have prostate problems. No, not they discover. They show up in a doctor's office when it's already in the bones. Juu wanaume wengi hawatakangi kuadmit wako na shida that pertains to their manhood. By the way, most wazees, they will never tell their wives, never tell their children, until a time when now they are obstructed completely. Hawezi pass urine. That is when there is a quick visit to the doctor's office, or catheter, or prostate, or PSA, imepanda, the one he was talking about. Kidogo kidogo, it's stage 4. Kidogo kidogo is in Texas Cancer Center, receiving chemo, radio, and surgery, and things just go up the roof. So what I can just say is, a healthy living that we are teaching here is not in vain. You know, somebody may think that the reason we are talking about health is just so that we are well. It's so that you avoid disease. You can avoid hypertension. You can avoid prostate issues. You can avoid breast cancer. There's no amen. We should venture more on preventive medicine. Amen. Then we can talk about curative medicine when we are there. So I think you have the chance right now as young people to adopt these lifestyles. Just say, Mimi, the only white thing I do is LNG white. And you're done. And you have prostate issues off the window. Back to you, Terry.
Well, the only white thing we do is Ellen White, si ndio? Sasa maswali kama mbili. Ngojea. I'll take 3. Aya, 1, 2, ready, go. 1. I'm saying 4. 1, 2, 3, 4. Hizo. Si ndio? Kuna ingine? I'm not even seeing a lady with a question. Anyway, the 4, okay? You can give them.
Happy Sabbath. Happy day. Thank you for the class, for the study that you taught us. I have 2 questions to both Onsare and Mtumishi. One, to Mtumishi, you said we have some nutrients that do well in, prostate do well, and you did not state them. I'm interested to know them. And at the same time, if they're in certain foods or certain grains, just state the name of the grains. The second question was to Onsare. You say that in Africa we are so much affected with prostate cancer than the other side. Does it mean, what are we doing that is wrong compared to Americans? And of course, are they not humans? Okay. So.
Okay. Happy Sabbath. Happy day. So I'd like to thank them for the informative session. And I have 2 questions. Number 1, you talked of the 1st degree risk. Once someone maybe in your family has been diagnosed of cancer, and you find that you are at a higher risk of getting this disease. Assuming I'm someone who has already recovered from that disease, any cancer disease that I had, maybe breast cancer, prostate, and I'm still okay, I'm living the lifestyle according to what is prescribed by the doctor. Now, what are the risks of me getting the same type of cancer, or the cancer manifesting itself in a different way? Another question, there are people who are not, they are practicing the 7th day, if I may say, way of living, the LNG White prescribed way. But you find that they are diagnosed of cancer, and then you wonder how comes. There is someone I was looking up to, and he really had a good way of life and the way he used to eat, But then he gets this, he's not taking alcohol, nor is he smoking. He has lung cancer. How, that thing scares me. Now, is it only about health message and lifestyle that will prevent us from getting this disease, or it's more than that?
Let's start with those two. We answer them and then we get the two questions.
Maybe I'll quickly speak, then he speaks. One, you talked about cancer recurrence, isn't it? I had some cancer, and how will I know that that cancer won't come back or another one? I just want to share quickly that cancer ideally, at the very foundational level, is not a localized disease. It is just that the manner in which cancer is assessed is based on anatomical structures. Cancer brain, cancer prostate, cancer breast, because that is the area it is manifested. But cancer begins with a compromise of the immune system, a compromise of the ability of the body to remove toxins, or and the liver be able to deal with so many things. So generally, the presence of any cancer in the body requires that a patient who has survived cancer needs to do more than treatment. Am I making sense? They need to have a radical shift in nutrition. They need to have a radical shift in lifestyle practices that could lead to the cancer, because at the end of the day, if the tank has a poison, you need to drain the water and put in new water. The same way, the body needs to go through a process that will help. And that is why we say patients who have cancer, what I would advise from a lifestyle medicine standpoint, they need to be on a juicing plan, a vegetarian diet, a stress-free lifestyle after remission, meaning after the cancer has been put under some form of treatment and the symptoms have disappeared, there is nothing indicating the patient has cancer. They should be put through a lifestyle program that allows a complete overhaul. Or else, if you do chemo, radio, surgery, you only have a window of 5 to 7 years. That is also researched for a recurrence to occur. So most patients, they can come even on a TV screen and say, oh, my breast cancer is on remission. Remission means it's the symptoms of cancer have all disappeared. Then you find 3 years later, oh, I have a lung cancer. Then the doctor says it's a spread from the what? The breast cancer that you had, which you are told had done what? I have seen patients who have cervical cancer go for surgery. The cervical cancer was taken care of. Then later on, they have a cancer in the uterus. So when they figure out where did it go, oh, the surgery he did 4 years ago, she did 4 years ago. So the point is, cancer treatment or remission is not the end. That is why for us, the way we've assessed patients, there should be a juicing. There should be a complete overhaul, eating of vegetables and fruits, exercise. If there was alcohol, cigarettes, whatever, zinatolewa. If there was overwork, it is taken out. The patient needs to learn that it took about 15 to 20 years to get the cancer. They need to trace the steps backwards to the point whereby which they can do a complete overhaul of the body. So cancer recurrence will always take place when treatment was the only thing done. Tuko pamoja? But if you understand that you need to completely arrest the body, you'll have a change. Number 2, cancer is not merely caused by issues nutritional. Genetics play a role. There are other things that somebody could be doing. Ameacha nyama, lakini alali. You get? Ameacha nyama, lakini maziwa anakunywa vibaya sana. By the way, there is a dairy implication in prostate cancer. Anakunywa 10 times. They are doing this, but they're not doing this. They're on sodas. I mean, at the end of the day, I think you need to be very patient with people who seem to be living healthy, who get sick. Because the sickness could come from an area that is not clearly verifiable. I can as well have cancer. I stopped taking meat in 2010. But I can as well have cancer. So what will you do with me? All those years of vegetarianism. It can come from something else. So at the end of the day, the foundational factors for diseases are varied. radiation exposure, maybe so many tests, maybe stress, maybe a lifestyle issue, maybe there is something I'm doing that I have not yet discovered well that is interfering with my health. So those rare cases should not bring a major issue. The question he asked on for me, I think the ones I'm skipping are the ones that I know are coming to you. Yeah. So the question he asked on, I did not give nutrients for what? For prostate. Generally, all the nutrients that are required for the prostate are not clearly indicated, but the common ones are ones linked with sex, production of semen, and other attributes that relate to sex. And that is why I said the key one is what? Is zinc. The only thing, the others could be there, calcium, magnesium, and all these others. But like I said, nutrients are very high in unrefined foods. Carbohydrates that are unrefined are the best in providing nutrients. That is why I said the jam. You are there during the week. I talked about the jam and the bran. The jam is very important. So that is why I make it a principle in your home, even here in school, that you will only eat food that is not impoverished. If you make that a maxim, you'll find greater strength, greater ability to perform other tasks, even in terms of your brain, you'll get much better. So generally, grains contain all those nutrients. When you refine them, you lose them. And like I said, refined sugars also leach the nutrients we already have in the body. So when you're taking soda, you're losing. When you're taking the white rice, you're losing nutrients because you need nutrients to process it. So the more you take of refined foods, the more you lose what you already had. And that consequently creates the same problem we are trying to avoid. Think, do you?
Okay, thank you. Okay, you asked about us Africans and prostate cancer. I think that's a good research topic. But speculatively, what I can say is a genetic link. There's a genetic linkage with Africans with the prostate cancer. Two, it's what we've been talking here. That the other cancers that are more prevalent in the West, like colorectal cancer, and what is implicated in those cancers is diet. So, I want to speculate that diet could be one of the risk factors to why we have more cases in Africans compared to the other guys from across the globe. The other question that Joram asked, maybe if I can add on what Mtumishi has said, we cannot overemphasize genetics in the pathophysiology of cancer. We can have genetics in the background with these environmental risk factors as additives. And if you have a genetic propensity to developing some type of cancer, changing your diet will not change your genetic code, that genetic code. We have talked about BRCA. We have other genetic codes for different cancers. So that is constant. But these environmental risk factors are only additive to the underlying genetic risk. So, if you avoid these environmental factors, just as Mtumishi has rightfully said, the timing of when you develop these cancers, could be prolonged. But your risk has not been abolished. I think that's important to say. The other thing is, just on the same question, patients with, say, breast cancer, it is not always that you have a first-degree relative with breast cancer that you will be at risk for breast cancer. There are other cancers that can put you at risk of breast cancer. See, colorectal cancer. See, ovarian cancer. So, if you have a relative with ovarian cancer or colorectal cancer, could not, maybe you have a relative who's a man with colorectal, you are at risk of breast cancer. Why? Because these genetic codes, the genetic mutations we are talking about, just like Mtumishi said, cancer is a spectrum. So if you have a mutation, say BRCA, we talked about BRCA in prostate. If you remember well, we also talked about BRCA in breast. So it is not definitive that once you get a mutation, you will get a certain type of cancer. You can have BRCA and get prostate, BRCA and get breast. Or there are other cancers that are related to breast cancer. So if you have relatives with that spectrum of cancers, you are advised to seek screening. Yes?
Okay, thank you. So I'm being crucified with regard to time. So, yes, I would want us to be a bit brief. The last two questions.
I thank you for the insights. Just a disclaimer before I ask the questions. Don't crucify me if I don't sound so biological. I led biology in Form 2, so I'm more of a philosophy guy. So I have 3 questions. Then some questions have been given by some people here. So number 1, on constant stimulation, that is when it comes to men. We talked about the flesh diet, drugs, things that can lead to that constant stimulation or whatever we watch, movies and all that. There are some plant foods that can also stimulate. That is another thing. I think this one I should have asked on Wednesday on sexual health, but I was not there. I watched online. Can kitambi affect the cable that is below the belt? Like having a kitambi, can it really affect whatever is there for a man? And on the part of holding urine, for example, you'll be sleeping and you feel like going out at 3 a.m. and simply because the sleep is sweet, you can hold it until morning or maybe about 6 is when you go out. So is it bad? Okay, sometimes I do it, so I just want to know if it is really okay. And there is a question on breast cancer. This one has been asked by somebody, and not anyone I know. I don't have a girlfriend, so I'm just asking for the sake. So how does prolonged breastfeeding lead to breast cancer? That is second last. Is on blood cancer. Is blood cancer only genetic, or there are other causes of it? And also on the part of vegetarian diet, we know the current world we are moving in. Does where the plants or where these things are being grown can really affect, for example, vegetables being grown in places where there are sewages and all that can it really affect that diet? Thank you.
Okay, the last question.
Good evening. So, if we all follow the health message this week, I think myself, Elder Dem and Davis will die poor, but we'll live longer with you and we'll all go to heaven. Quickly, I have one last thing to add. when you talk about the risk factor of oral contraceptives and cervical cancer, I think it's important to outline that there is a behavioral component to it. Because if somebody is using oral contraceptives, they'll say, I can't get pregnant, so there is a likelihood of reckless sexual behavior. So the relationship between cervical cancer and oral contraceptives sometimes is a behavioral component. So somebody can end up using, say, IUDs, they become reckless again and they get pelvic inflammatory disease, yet they were running away from cervical cancer. So I think that's important to note. Then my question is, can men be vaccinated against HPV, and should they be vaccinated against HPV to deal with the mosquito problem that Terry talked about? Thank you.
Okay, I think for the interest of time, I'll pick on some of the questions that I think I've seen the brother on the other side has talked about. I want to begin on the plant issue. The health message is grounded on principles. Their application cannot be exactly the same. By that I mean, we are not eating from the same table. So I may eat more fruits than you, but we are all to eat fruits. Making sense? I may drink more water than you, but we are to drink a recommended amount of at least a given level or range. The same also applies. We have a common stance against a flesh diet, and I think that is something that I wanted probably before I finish. I give a glimpse because some of us do not know how critical the issue is about. But a flesh diet is an area in health reform that our church places on the same category with tea and coffee, meaning it is something we are to do away with. So the alternative, according to my brother's question, is we have plants, India. But where they're grown is what? Is having either herbicides, pesticides, or toxins, or all those challenges. The counsel I can summarize we are given is to do the best we can. To do the best we can means in the circumstances where we live, we need to take extra effort to get food that is fresh, that is healthy, and if we cannot get the very best, we use the one that is available. I'm thinking at the end of the day, unless the food I'm getting is growing in a sewage that I can see, I would still rather take a plant diet than eat flesh, of which, from the word of God and the spirit of prophecy, I have been given a decided testimony as to the impact it has on my body. Number two, plants are more forgiving than sick animals. Plants are more forgiving than sick animals. By that I mean the impact of eating an animal that is sick and a plant that is sick. Plants have better ways of dealing with toxins and removing wastes from themselves than animals do. And that is the reason why at the end of the day, the ideology that I want us to have across is God wants us to do the best we can. The best we can in the circumstances that we are, is that you can still get vegetables. Even though they have those challenges, there are things you can do. One good example, those ones who eat a lot of vegetables, for instance, in our lifestyle center, almost all the people that we deal with, we put them on juicing. Do you juice raw vegetables or you juice cooked vegetables? So that means if they have herbicides, if they have pesticides. So what we do is after bringing the vegetables, we soak them in water that has, warm water that has charcoal. First of all, they are washed. They are washed. If they are carrots, they are washed even using a brush, meaning they are washed thoroughly, externally, to ensure that they are very clean. Then they are soaked in warm water that has activated charcoal to draw whatever toxins that could be within. Then they are dried and left to rest for a while. That is when they are refrigerated. Then now they can be used for the juicing, because the patient will be taking this juice with the hope that it will help them. So that kind, in one way or another, handled to a bit the idea of toxins and herbicides. But doing the best we can is what God recommends for us. Holding urine. Generally, the bladder is supposed to signal the individual who has a bladder that it is full so that you can evacuate. When the bladder is full and you hold the urine, urine is a waste product, you are putting a high risk of impacting the kidney, at the same time the surrounding tissues and cells with that toxicity, which can lead to an illness. I know there are certain kidney failures that arise from prostate issues that led to a partial blockage that the patient dismissed. So the kidneys used to get this backflow of urine because the bladder was always full and the person could not empty over time. I think generally, health-wise, it is not recommended that you hold waste, both in your bowels, by that I mean in your colon, and within your bladder. If the time has come and the body has given you alert that you are supposed to release it, it is better that it is done at that time, because the toxins remaining in the site of tissues and cells will at the end of the day interfere with the surrounding tissues and cells. The other question you asked was? Prolonged breastfeeding, I think he'll respond to that. The other question you asked was? I think that one I want to dwell on, and I also want to put more weight to what he shared earlier about cancers. I want us to remove the perception that we want to place responsibility on genetics for the modern day chronic diseases. There's something I said earlier. What did I say? Genetics load the gun. Meaning genetics are only a predisposing what? Factor, but the lifestyle choices of the individual already predisposed will determine how quickly they get the condition. Whether it's hypertension, whether it's diabetes, whether it's cancer, whether it's prostate, whether it's leukemia, at the end of the day, genetics only load the gun. So at the end of the day, there is something called epigenetics that Dr. Rainey, I think, talked about on Thursday. Yeah, on Thursday. Was it Wednesday? Wednesday. And epigenetics is a study of how genes operate, and it has been discovered by science that lifestyle changes can actually close or shut down some genes and activate others. Meaning there are some lifestyle changes that if an individual makes, everyone in their family can be having diabetes. Now, this is because there are some things you can switch off and some things you can switch on. So if there are certain genes of cancer predisposition that has been found in a family line, you need to figure out in the health message, what can you do to avoid the disease? So there are other causes of cancer. Blood cancers have several causes relating to even toxins, exposure to radiation of any type. They can go all the way to dietary implications. But at the end of the day, if there was a genetic connection, those implications come based on the choices the individual makes at the end of the day. So let's remove the responsibility of our illnesses on genes. And let's narrow down to the fact that there's something we can do about it. See, that is much better. I think that will help us face disease with much more strength and focus. I think, Doc, you can deal with a few that I have not handled. There's a question, that was a question, or I think I had answered it. Yeah, back to you.
So I think I'll be quick to answer. About breastfeeding and see a breast, we said it's protective. We did not say it is a risk factor. Breastfeeding is protective to see a breast. About holding urine, there's a reason as to why you get the urge to urinate. It's physiological. If you hold, urine has so many components. and including bacteria. So if you hold urine within your bladder for long enough, you are giving bacteria room to multiply, and you can have conditions like cystitis, which is part of the spectrum of UTIs. And like Tumishi said, you can also affect your kidney because of ascending infections. Conditions like pyelonephritis, yeah? So it's not a good practice to hold your urine. Also, you are stretching your dextrosum muscles, and by stretching them, it means that as you age, you are one person. Okay, I'm not referring to you. Generally, as you age, the dextrosum muscles of the bladder tend to be lax. There's that laxity. If you stretch them, you overstretch them when you're young, when they can contract well enough, then it means that they will lose their contractile properties earlier than the normal population. And you are the kind of, okay, so I'm sorry I'm referring to a person. But now that you said you practice it, yes, you will have issues in old age that you should not be dealing with. Let me be quick. Thank you, brother, for that contribution on CA cervix. Let me talk about contraception and the behavioral component he talked about. In prevention, we said sex, sex, sex. Multiple partners, high-risk partners, low, earlier age onset of coitus. That's behavioral. I don't know whether this is a fun fact, but condoms do not prevent you from getting HPV. Condoms only prevent you from getting STIs. Research has shown that HPV, the virus, can penetrate latex. The only advantage that people get from condom use is because we talked about STI and its implication on CA cervix, is because you will be protected from sexually transmitted diseases, especially those ones that ulcerate. You will be prevented from immunosuppressive infections like HIV. And therefore, even if you get the HPV infection, the rate of progression will not be as fast as the general population. I'd love to talk about contraception, like combined oral contraception and estrogen, but we don't have time. Maybe this is a conversation that we can have, and how the contraception, the combined oral contraception, for instance, causes cancer. Go read about cervical extropion. There's something called cervical extropion, and discover more about contraception and CA cervix. Yes? Men and HPV vaccination, yes. We have said that men, quote unquote, are carriers of HPV, and we are the people who infect the women. Therefore, vaccination for men is how can I put it? Is recommended. Men can be vaccinated against HPV. I think that's all because of time. Thank you.
Yes. Unless you have something to add. No. Okay. I think that has been an interactive session. You've learned, right? If you can teach other people out there, it's all about awareness. Educate. It's an important aspect of life. Otherwise, thank you so much.
I want to sell the expo to you. So tomorrow we are having an expo, as you are aware. We will be having so many services spanning from blood donation. We'll have cervical cancer screening. We'll have breast cancer screening and education. So tomorrow will be a continuation of what we have had this afternoon. So, if you do not want to be examined, you can learn. We have talked about contraception and their risks. You can learn, you can spread the information. We are also screening for blood pressure. We are screening for blood sugar and BMI. So please spread the gospel. Okay, yes, we are also screening the eyes. We have a sponsor, a partner who will be doing that. So those are so many services that you wouldn't want to miss. So spread the gospel. What we're doing tomorrow is a continuation of the gospel that we have had today. It's a part of preaching, if I may put it so. So please come, especially for the screening services that we'll be having. Thank you.
All right, we'll rise for a word of prayer.
Okay, let's pray. Heavenly Father, we thank you for guiding us through this session. We pray that grant us the grace to adhere to what we've learned, what we need to learn, Father. Open our hearts that we may hear. Those that we need to change in our lives, how we pray that may your Spirit guide us through and accord us the strength. These are our prayer in the mighty name of Jesus Christ.